Good afternoon, everybody. We'll be starting this video-based course on customized corneal transplantation. With me, I have my co-instructors. Dr. Praveen Krishna could not be here, so he has sent a pre-recorded talk. We have Dr. Namrata Sharma, Dr. Sharon D'Souza, Rishi Swaroop, Pratik Gujjar, and Dr. Samar Basak, and myself. And we will be trying to give you a quick overview of all the latest in lamellar keratoplasty in this video-based course. The first topic is on superficial anterior lamellar keratoplasty, and we will play Dr. Praveen's recorded talk.
Hi, good afternoon, and my sincere apologies for not being able to be here in person to speak to you about superficial anterior lamellar keratoplasty in this amazing course that Dr. Rajesh Fogla has put together. But I'll try and do my best to share with you some of my thoughts in superficial lamellar keratoplasty in the next 8 to 10 minutes or so. Hope you have a great conference, and I hope to see you tomorrow, which is when I'll be at Cochin. So the kind of patients who might benefit from superficial anterior lamellar keratoplasty, which is called SALK for short, to differentiate it from the deep anterior lamellar keratoplasty or DALK, is a surgery that is limited to the anterior stroma of the cornea. So technically, any surgery that does not reach up to the desmase or the predesmase layer can potentially be called SALK. But in general parlance, SALK is referred to surgeries that are limited to the anterior 300 microns of the corneal stroma. So it is useful or beneficial for people who have pathology in the anterior 300 microns of the corneal stroma. So includes corneal scars, degenerations, and some dystrophies as well. So before we actually look at where SALK is going to be beneficial, I think it's important to explore the various options that patients who have superficial corneal lesions might have. And this is based on the kind of corneal lesions they have. So you have corneal lesions like in dystrophies that might have a surface that is smooth, or you might have lesions that are slightly elevated or extremely elevated, like in spheroidal and in Salzmann. So what actually will benefit which patient is the goal of the next couple of slides. So the two different kind of lesions that you have on the cornea can be categorized into lesions that are non-elevated, and these are lesions that have a smooth epithelium in spite of the opacity being irregular, and this happens over time because of the amazing potential of the epithelium to smoothen the surface of the cornea, and can also be imaged by topography to look at, to identify the amount of smoothness or irregularity on the surface. The second kind of lesion is the elevated lesions of the cornea, and the typical prototype of this lesion is Salzmann nodular degeneration, and you have a lot of lesions on the surface of the cornea, including scars on the anterior surface that will fall into this bucket, where SALK is a great option. So how do you differentiate, and how do you choose which surgery will be most beneficial for which patient? If you have a lesion that is non-elevated, that is, it is flat on the surface, versus a lesion that is elevated, for non-elevated lesions, you have to again differentiate whether the epithelium is smooth or not. So non-elevated lesions, you can identify on slit lamp examination. If the epithelium is smooth or irregular, you can identify on topography. Now, if you have the epithelium that is smooth, the ideal surgery for this kind of lesion will be a transepithelial ablation, and then to do a PTK after this one, which will help in removing the lesion as well as smoothening the surface. In case you have an irregular epithelium, you can debride the epithelium, and then you can do a PTK using a masking agent. These are for non-elevated lesions. And again, the typical example of a non-elevated lesion is a patient who has post-PRK haze, as you see in this example, where though the haze is irregular with a sawtooth kind of appearance, the epithelium is smoothing it out and making sure that the topography is regular. These patients do really well with a PTK because the lesion is relatively anterior stromal and the surface is smooth, so a transepithelial PTK is a great approach, and you can remove the lesion in its entirety. We won't be going to the details of this, but that's for another day. Now compare that with elevated lesions on the surface of the eye. This is a patient who has a localized Salzmann nodular degeneration, and the ideal surgery for Salzmann is just to peel the lesion off the surface of the cornea. Most cases, the Salzmann lesion is on the surface, and you can remove it without too much disturbance of the surface of the cornea. And if you have significant scarring or irregularity, you can even do an AMG if you would like to in these corneas as well. But this is an example of the same patient that you saw in the first slide, where the Salzmann has been removed just by peeling off the surface of the lesion. What do you do when you have denser lesions that are slightly deeper in the cornea, which might not be amenable to PTK, might not be amenable to also scraping or removal of the surface? Well, you have alternatives, and these include mechanical debridement, which is useful in some cases of spheroidal, some cases of anterior variant of the superficial variant of the granular corneal dystrophy. But you also have SALK, femtosecond ALK or FALK, and DALK. Now, ALK can be done either with a microkeratome or can be done using a manual method. And I think Dr. Namrata Sharma is going to be speaking about microkeratome assisted ALK. And you'll see that in the subsequent talks. But the problem with microkeratome assisted ALK is the fact that if you have a surgery done for a lesion, typically you'll need to place sutures. And the reason why you need to place sutures is because you might have a mismatch either in the diameter of the graft, or you might have a mismatch in the thickness of the graft, which is the reason why you'll need sutures. The other interesting aspect of a microkeratome assisted ALK is if you have an irregular corneal surface, then you will replicate a little bit of that irregularity onto the bed as well. And so the topography is, if it's irregular, you're going to have an irregular topography after you do a microkeratome assisted ALK as well. Now, one of the variants that has been described has been FALK or FALK, where you can do the same kind of surgery, but with a femtosecond laser. Now, the big advantage with doing FALK with a femtosecond laser is the fact that because the mismatch of the diameter is so minimal and the edges of the flap that you create are so vertical, you can effectively place the corneal tissue that you harvested from the donor onto the bed and leave it in there to stick just like you would do a LASIK flap, and you don't require sutures in this kind of situation. So this is a case where there was a corneal scar, and then the corneal scar is being removed after the femtosecond laser has created a cap, and after that has been removed, you will see that we will replace this with a corneal cap, which is cut to the exact same diameter, and you'll see that the cornea appears very clear, and you don't require sutures for this, which is probably one of the biggest benefits of early visual rehabilitation. Now, FALK, though it sounds really good, if it's used for eyes in whom the surface might be slightly irregular, like you have in granular corneal dystrophy, you will have very good outcomes because this is post-FALK and the recurrence rates are pretty low as well. And this is a great option. But if you use it for patients who have an irregular corneal surface, like you see on the corneal scar in the picture on the top left, preoperatively, postoperatively, anatomically, it looks great. It looks like the scar is completely gone and you've got a great outcome. But if you look at the OCT below, you'll see that the bed is actually quite irregular. And this is because of the fact that the surface of the cornea was quite irregular as well. And so the surface irregularities are sort of copied or xeroxed onto the bed, and you will have irregular astigmatism in these cases too. So the other issues with femtosecond anterior lamellar keratoplasty is the fact that the deeper you tend to go, the more irregular the cut becomes. And so if you have a opacity that is in the anterior 200 microns, you'll have good results. But if you have to make a cut that is deeper and deeper because the laser has to traverse to a greater distance, you'll tend to have more irregularity in these situations. So very quickly, I'd like to share a case with you where we did femtosecond assisted anterior lamellar keratoplasty. This is a patient who had microkeratome LASIK and then epithelial ingrowth, underwent debridement and flap lift and removed the ingrowth a couple of times, but the patient had recurrent ingrowth and the ingrowth was quite deep. And since the surface was quite smooth, we decided that we're going to be doing an FALK for her. And the FALK worked out pretty well, and this, you see, anatomically had a great outcome. and the patient was relatively happy. Obviously, you'll see that the bed again is a little irregular, and you can see that Bowman's as well on the surface is slightly distorted. So the patient actually required contact lenses for good vision. It's another matter that we were able to do a topoguided PTK and then a PRK later on for her, and then she achieved an uncorrected vision of 20/25. But that's several interventions. So FALK, to summarize, is a great option in anterior stromal scars and in lesions that have regular corneal topography. If you have denser opacities, it's a little more difficult to do, and you will have issues with interface irregularity and sometimes residual haze as well. Very occasionally, you might have sizing issues, but the majority of times, this can be a sutureless cell. The biggest advantage of FALK is that you have early visual rehabilitation. But coming back to the original topic of our discussion of what do you do when you have elevated lesions on the surface of the cornea. We saw that when you have non-elevated lesions with a smooth topography, we will actually do either, you have to evaluate if the lesion is less than 100 microns deep from after the epithelium, then you will do PTK. If it is greater than 100 microns, then the preferred surgery will be a FALC or even a microkeratome-assisted ALK. This is only if you have smooth topography. But if you have irregular topography, then, and if the lesion is less than 250 microns, then LK or ALK or SALK is a great alternative. If it is irregular and the lesion is deeper, you might actually be better off doing a DALK as well. So now, where does this fit in? You see that superficial anterior lamellar keratoplasty is
We'll pause at this because his presentation is still a little longer. It covered the aspect of superficial anterior lamellar keratoplasty. The next talk will be by Professor Namrata Sharma, and she'll be covering the topic what Praveen was talking about in this, of doing microkeratome-assisted anterior lamellar keratoplasty, and she will also touch upon the role of intraoperative OCT in performing lamellar keratoplasty. Professor Namrata Sharma, please.
Thank you, Rajesh. Thank you for this wonderful course, and thank you for making me a part of it. So I would be talking to you about microkeratome-assisted anterior lamellar keratoplasty, and there are no financial or proprietary interests. Now, depending upon what level your opacity is, the microkeratome can be used. Praveen has very nicely covered the superficial automated lamellar keratoplasty, which is the SALC. But if the opacity is deeper, then you have to do what is called as automated lamellar therapeutic keratoplasty or ALTK. And sometimes it happens so that you are able to dissect the donor cornea with the help of the microkeratome, but you are not able to dissect the recipient cornea because of irregularity, and then we call it HALC. So sorry for that error. It is hemi-automated lamellar keratoplasty. Of course, the advantages of ALTK or SALC are there. There's hardly any graft rejection. It is extraocular. There's less astigmatism. The donor quality criteria is less stringent, and there's less astigmatism. Apart from the various things that you actually look at in any case in a preoperative evaluation, such as conjunctiva and cornea, I think the most important thing or most important investigation that you need to do is the pachymetry and the anterior segment OCT, because you need to see at what level the opacity is. So superficial anterior lamellar keratoplasty, I would say, would be, say, even you can go up to 200 microns, but below that is going to be the automated lamellar therapeutic keratoplasty. So manual keratoplasty has a problem because of the irregularity of the surface, because you're doing a manual dissection, which can lead to interface haze, especially over a period of time. And this instrument has completely revolutionized the way we are doing our surgeries now. That is the microkeratome. When you use the microkeratome, it is technically easy, less time consuming. There's a smooth or host donor cornea cut, and thickness is nearly exact with no interface problems. So you can do this technique for all the cases. Probably for this case, you would need to do HALC because it is difficult to cut through the microkeratome, especially if there are areas of thinning. But in all the other cases, ALTK can be done. This is just to show how it is done. So this is a keratoconic cornea where the microkeratome is being used, which is 350, which is going to split the cornea into 350 and 150 microns. So the anterior part is taken, and this is the keratoconic cornea. Again, the recipient bed is dissected, and subsequently one places the donor cornea, which had been previously dissected, onto the host. And because in this case it has gone deeper, so you have to suture it. In case it's superficial, one can just put glue. So there is an interface to it, but important thing is that the interface is quite clear. It is not hazy as in case of manual lamellar keratoplasty. These are some of the results of ALTK in various indications, and you can see the corneas look quite clear. Now this was of course SALC, and so I think I'm going to skip that, except that probably I just want to highlight that there are two microkeratomes which are available. One is with the Moria, which I showed you earlier, and this is the one with the Gabor. Both work equally well, but in my experience, ALTK cuts a little more than what is desired, say by 40 to 50 microns, and this cuts a little less than what is desired, again by 40 to 50 microns. And this was a case of, in fact, dystrophy where SALC has been done, and no sutures are put, so you put a bandage contact lens. And I always like to put an inverse kind of a bandage contact lens because that leads to a better fit. So this is just to show the post-op pictures of the anterior segment OCT. And in cases of ALTK, the fit here is quite snug. Again, sometimes what may happen is that there may be mismatch between the donor cornea and the recipient cornea. So you will have to titrate that part also. And this is again to show in the post-operative period how well the healing at the graft-host junction as well as at the interface occurs with hardly any haze. But these are some of the results of ALTK and SALC which have been there available in literature. And again, the results are quite good. Best corrected visual acuity of 612 or better is seen in 70 to 94% of the cases, and most cases would have astigmatism of less than 4 diopters. We were one of the first to publish our results way back in American Journal of Ophthalmology on various indications of ALTK. Now, this is a publication, a 12-year outcome of microkeratome-assisted anterior lamellar therapeutic keratoplasty, comparison between children and adults, which very clearly shows that there were a little more problems with the children as compared to with the adults. Now, this is an elegant paper by Dr. Rajesh Fogla, again, which looked at the stage sutureless SALC procedure for Rees-Buckler corneal dystrophy with very good results and no recurrence at all. Again, this does talk about SALC, but this is SALC for anterior corneal stromal opacities after penetrating keratoplasty. Again, it is a reality, especially if you have a anterior haze. And these are our results where we've looked at sutureless anterior lamellar keratoplasty with phacoemulsification, because in these cases, you can have cataract and you may have to even address that. This would be essentially what is called as the hemi-automated lamellar keratoplasty, or HALC. And the studies of this have been published by the SNSE group, where the dissection of the recipient bed is actually done manually because of the irregular surface or corneal thinning, and the donor is cut with the microkeratome. Again, long-term studies, 5-year results with the ALTK, which shows very good results across all parameters, including visual acuity, the spherical aberrations, the cylinder, etc. There can be problems. Post-op problems have been reported in some of the cases, like rejection, epithelial defect, myopia, also an infection in one of the grafts. This is again a variant, and I think Dr. Praveen also alluded to this, two-piece mushroom keratoplasty, which is advocated by Dr. Busin, and sutureless superficial anterior lamellar keratoplasty reported in one case in recurrent corneal haze after repeat excimer laser surface ablation. Again, these cases can be very difficult because they have been done, the excimer laser has been done for them, and haze is there, and that has to be tackled. So SALC can be one of the options. Now, it's not a procedure without problems. So this is just to show that you can have perforations. Like I said, sometimes you do gauge you are cutting what it would also depend a lot on what the pressure is inside your anterior chamber when you are making the cut. If the pressure is too high and the cornea is too steep, then you may have a perforation such as is shown here. Now, at times, what may happen is the recipient is a little bit hazy, and so we do try to do a microkeratome cut here, but we realize that it is still hazy, and you may have to tackle that by doing the dissection manually, and then following which the cornea here, in this case, it is a biosynthetic cornea which is being placed, and subsequently the glue which is being done. So both microkeratome assisted ALTK and SALK, I think microkeratome is one thing which has revolutionized the way we do lamellar surgery, not only for anterior lamellar keratoplasty, but it has taught us how to do even endothelial keratoplasty, something that we were not doing earlier. It is about the smoothening the surfaces. The intraoperative course is more or less predictable. The postoperative outcomes are optimal, and there are hardly any complications. Thank you very much for your kind attention. So I'll go with the second talk, Rajesh.
You can go
So
ahead.
for the want of the time, I think I will go with the second talk, and this is how an intraoperative OCT helps you to do various kinds of keratoplasty. Of course, you can do it even without it. It just helps to fine tune your steps, and it allows you to see what you were actually not seeing earlier, and you would have to just imagine it. There are no financial or proprietary interests, and this OCT is a non-invasive diagnostic technique that renders an in vivo cross-sectional view of the optical tissue while you are operating. Now, we have experience with the microscope integrated OCT, which is integrated into the microscope itself, and the advantage is that it gives you real-time images, dynamic visualization, and in the same eyepiece where you're doing surgery, you can actually see the OCT picture. Of course, the flip side is that it is expensive and it may not be available at all centers. So there are various techniques of DALC, and the big bubble remains the gold standard. And you can do the big bubble. Could be a type 1 big bubble such as this, or it could be a type 2 big bubble which is there just above the Descemet's membrane, or type 1 big bubble is just above the Dua's layer. And when you're doing it, actually, this is a partial thickness trephonation which is already done in a keratoconic cornea, and the air bubble is instilled in the supradescemet's membrane compartment. So in a real time, you can actually see this into your operating microscope eyepiece, that where the air has gone. So air has gone just above the Descemet's membrane, and as you give a nick in the overlying stromal layers, the air is egressing out and the Descemet's membrane is marching towards these stromal layers. And this is like a live show. So now again you inject viscoelastic to reinforce that compartment which had previously been created, and like a kangaroo's pouch, it drops down, and then the overlying stromal layers can be dissected, and the bare Descemet's membrane is staring at you here. You have done the surgery and you are still extraocular. So it helps you to see dynamically what is actually happening. Now, this is the type 2 big bubble, where the big bubble is going from the periphery towards the center. It is marching towards the keratectomy site, and just once it comes here, it can stop short. Now, another important thing is that when you're putting the needle, you know exactly at what level it is. So when you are about 80% depth, you know that you are in the correct direction. Now, again, when you do AC paracentesis, you can see the dynamics of the Descemet's membrane, what is happening to it as you do the AC paracentesis. And as a nick is given here, it is going to move very fast. So by the way it moves, you come to know type 2 bubbles generally move very fast, as opposed to type 1 big bubble, which march a little slowly forwards. So then the rest of the steps could be the same. Now, it is very helpful. It is very helpful to allow you a supradescemet's membrane dissection. So as you put viscoelastic into the supradescemet's membrane compartment, and as one sees it, one can see that you are coming very close to the area where you have to dissect. So you can keep reinforcing this supradesmoid membrane compartment with the help of the viscoelastic agent so that it drops down and can continue your dissection without perforating the desmoid membrane. Now, very useful in cases of healed hydrops, where actually you can see where the scar is. So, when you do a manual lamellar dissection after doing a partial thickness trephination, in the area where the scar is present, by looking at the picture here, you can go a little anteriorly so that you don't rip that scarred area open and the desmoid doesn't perforate in the area of the scar. And so you go a little anterior. It doesn't matter if a little bit of haze is left in the paracentral area, because ultimately the patient still has good vision because that thing has moved out of the periphery. So I think I'll skip this and we'll come to the post-op cases. Sometimes you have graft dehiscence such as this here after DALC, and again these cases can be tackled using the intraop OCT microscope, where you can actually see where the dehiscence is and where the desmoid membrane is without having to perforate the desmoid membrane. Now, coming to DSEC, in cases of hazy corneas, it allows you to see where your graft is. So here, you can't make out where the graft is, but when you look at here, you know exactly where the graft is. It is floating somewhere in between. And as you put the air bubble, you can actually see the graft moving up. And now you would think you are done, but you're not done, because there's still some microscopic area which is there. And as you hydrate, this kind of moves again. So you can titrate your endpoint and can just instill air bubble over there, and then you know it is quite stuck and it is not going to move. This is what we had published on DSEC, IOCT guided DSEC. Again, in DMEC, it is very useful. I think there is nothing about, not too much of use when you are preparing the DMEC graft, because the desmoid membrane is stained, and so you can actually see what is happening to the roll, and it doesn't yield anything much, except that if you have taken a pseudophakic cornea, then you would know where the adhesions are present on the intraop OCT microscope. This is the S-shaped stamp which is being put, and subsequently this graft which is harvested. This is being done by, I call it Dr. Samar Basak's technique, because we've all learned DMAC from him. He came to RP Center for a workshop. So when you are now doing a DMAC in a case of Fuchs dystrophy, as you do desmoid membrane stripping, one can actually see, and if there are any remnants which are there, one can actually see on the posterior surface of the cornea. This is the desmoid membrane roll which is being put, and this is an upside down roll. And this is the correct side up with the biceps curl upwards, and here the air bubble can now be instilled, and then you know that the correct side is up. Again, this is the post-op picture in the same case. This is a hazy cornea where stamping of the donor cornea has been done, but you can't see anything. Coupled with that, there are also desmoid membrane tags which you can't make out where they are. So after the graft is put inside, you can see the configuration here. It's a tight scroll. And then as the biceps curl upward configuration comes into being, then you can just tap and can instill air. Can't still see the S very clearly, but as the graft gets stuck to the back of the cornea and you put a little blob of viscoelastic, you can see that the correct orientation of the S is there. Again, there can be folds in a DMAC graft such as this. So you put air bubble, the fold is there which can be seen on this side. This part of it is folded. So from one side, inject fluid and put air bubble after that once the fold gets unfolded, which again can be seen here as you put the fluid, the fold gets unfolded and the graft then gets completely attached to the back of the cornea. Now, this is again useful in cases like DMAC for failed DSEC, post-penetrating keratoplasty. The DSEC graft has got quite stuck to the iris, and again, this is an upside-down graft, so I wouldn't load it in this direction. I would load it the other way around, where the biceps curl is upwards, so that it goes biceps curl upwards inside, and that's it. So I would conclude this by saying that intraoperative OCT is a useful tool in armamentarium of keratoplasty surgeons. It helps to see the third dimension and it helps to refine your surgery much better. Thank you very much for your attention.
Thank you, Professor Namrata Sharma, for this nice presentation on both the topics. We now move on to Dr. Sharon D'Souza from Narayan Netralaya, and she'll be talking about pearls for big bubble deep anterior lamellar keratoplasty.
Good morning, everyone. At the outset, a big thank you to Dr. Rajesh Fogla for including me in this wonderful course. So jumping right into it, I don't think any of us needs to discuss why we have DALC. Of course, by leaving behind the endothelium, we do have a much better opportunity of preventing rejections and other complications. So wherever there's an anterior pathology in the cornea, we prefer to have some form of an anterior lamellar keratoplasty, as you heard from the wonderful talks before. The indications for DALC, again, are varied, and we can decide what procedure works across the different conditions. The points to keep in mind, whether we're planning a manual DALC or a big bubble DALC, of course, is the underlying pathology which is there, the depth of scarring, which is very, very important, why that scarring is there, whether it's a post-hydrop scar or any other scar, and whether it's a central or a decentered scar, and of course, how the endothelium is. So there are various DALC techniques that we are aware of, and today I'll be discussing about my experience with the big bubble technique. So the great thing about many of our cornea surgeries is that we don't need too many very specialized instruments. There are a few instruments which can be got, and they really help for the surgery. So if you look at it from the steps of the surgery itself, the first thing we need, of course, are some form of trephines. So suction trephines are very useful. You get a very beautiful cut which is guided, and it is a guarded depth knife. You can also have handheld trephines, but in that case, then you need to combine it with a guarded depth knife, which you decide on. There are further anterior lamellar dissection. If you're planning to have it, the lamellar dissectors or the crescent blade. And of course, then for the bubble itself, you can either do it with a cannula or a gauge needle, 30 gauge needle. And very importantly, one instrument which I think is really helpful are blunt tip scissors. So the critical steps when we start the surgery, it's very important to mark. You can mark the center of the cornea, the center of the cone, and also measure what size you want to have your trephination. It is advisable, if you can see the Fleischer's ring, to try and include the Fleischer's ring because it's at the base of the cone. So then you are sure that you have included the entire cone, and the risk of you leaving behind part of a weak area is reduced. And of course, if you have a decentered trephination, then you can have problems ahead when you form the bubble also. So that's very important. The next thing which we come to are the partial thickness trephination. As I said, if you're using a suction trephine, then you have to measure pre-operatively and then use the trephination to mark. But what I do is use a handheld trephine followed by a guarded depth knife. Usually the keratoconus, no matter how thin it is in the center, the periphery will still be quite thick. So a 300 microns guarded knife is fairly deep enough. And it's important to go deep enough because that is a very, very important step to try and get the big bubble repeatedly, is that you have to go deep enough. And as in our learning phase, we tend to go superficial from the fear that we will perforate. The next thing is the anterior layer of dissection, which helps to debulk the cornea. This is not an absolutely essential step. Many surgeons would go ahead with the big bubble even without this, but it does help. If you debulk the cornea, then you have a much more predictable depth assessment when you're forming the big bubble. So you can go ahead and do this. Of course, if you have a very thin cornea in the center, that will again hamper your formation of the big bubble if you remove the entire layer, so you can leave it as a flap. So coming to a few videos about the big bubble itself, a few things that we need to keep in mind when we are injecting for the big bubble is the needle. So as again, initially we are very scared of perforating, so you tend to be very peripheral or you are very superficial. So you have to aim for, either the, maybe not exact center, but at least mid-periphery. Don't be too peripheral, and the direction is central or paracentral. And of course, we are scared that if you go too deep, we'll perforate. But if you're too superficial, you're going to get a lot of emphysema and will not get the bubble. We'll come to how we can predict that further. Next thing is, once you form the bubble, you have to release the bubble. Okay, and this is by what we call the brave slash. But before we reach the brave slash, and this will loop, so I just had a few points to show. Before we go to the brave slash, one thing is the paracentesis, because you want to make the eye a little soft. So you see the paracentesis is a very short incision. Following this, we put in air, which is the double bubble, which has been described even by Dr. Namrata and group, and then the brave slash. So before doing the brave slash, I put a blob of cohesive viscoelastic on the cornea. This has two advantages. One is it slows down the egress of air when we are releasing it from the bubble. And secondly, it's more visible that the air has escaped. The other thing which really helps us to assess whether the bubble has actually escaped is the air in the AC. So if you see that, now the air is in the periphery in the AC, and once you've released the bubble adequately, the air from the periphery in the AC moves to the center. If you don't put the air in the AC, what happens is sometimes if you have a little emphysema, it may look like some air escaped and you will mistakenly think that you have released the bubble. But actually the bubble is still there. So this really helps and has been very useful. The last thing about this step is that initially we used to make the brave slash very vertically, but now, we've learned over years that it's okay to go in a little more horizontally. You can use the normal side port or paracentesis blade. So, go in a little more horizontally and move upwards. This way, the risk of you perforating the DM when you're making the brave slash is significantly reduced, and actually the air will not escape till you pull out your blade. It doesn't release as soon as you enter. The last thing is the posterior dissection of the stroma. So, of course, we do a quadrant incision and removal. Very importantly, here the blunt tip scissors are extremely useful. So, what you have to see is that after you've made the brave slash, your scissors should pass smoothly into the plane which is created between the posterior stroma and the DM or predesematic layer. If it is not going in smoothly, it means you're not in the right plane, and this can happen if your incision is too small or there's a lot of superficial stromal emphysema. You have to remove the ledge as much as possible, and here we try to keep the blades of the instrument as vertical as possible, because it's very important to have minimal ledging to ensure a good apposition of the graft-host junction. Remember that the perforation, even though initially we are more scared of perforation in the center, you can have a perforation even at the periphery, because there will be a few additions of the posterior stroma to DM. So make sure you separate this well and then cut through. There are a few challenges, of course, but as long as we can keep a few things in mind, it's always a good easy enough. This is one sign which I have found to be quite useful. So if you notice the video on the right side, these very fine spoke-like structures are seen out of the emphysema, which will then, which will then predict the formation of the big bubble. And this would not happen in a normal emphysema. So if you normally our teaching is if you have a lot of emphysema, you must stop immediately, otherwise you're going to get a full emphysema all over the eye. The other thing is to understand the dynamics of the air. If it's trying to come backwards, better to stop, that you're not going to get the bubble. And of course, if it's tracking along the limbus, again, you're not going to get a bubble. So try to avoid keeping on injecting air in these steps. The last thing is that if you cannot find the bubble, as I said, it can be due to do two things. One is the incision is too small. In that case, you will have to find a way to increase the incision. Marking before you make your incision is very useful. It helps you to avoid losing that spot where you made the deroofing incision. So overall, obviously DALK is something that has been very useful. Big bubble DALK is a very useful technique. And if we keep in mind a few salient topics and points, it does give us repeatable results. And very rarely do we need to convert to a full thickness keratoplasty. Thank you very much.
Thank you, Sir, for sharing the pearls of performing a big bubble DALK. And so we now look at the other aspect of performing a non-big bubble DALK or a manual DALK. And who other than Rishi Swarup to talk about the manual technique of DALK. He has popularized the groove and peel technique as well. So over to you, Rishi.
Thank you, Dr. Fogla, for making me part of this wonderful course. And it's really a privilege to speak here. So my topic is my technique of manual DALC, which I call the groove and peel technique. So why would you do a manual DALC if you can do big bubbles so beautifully demonstrated by the previous speaker? You don't always get a big bubble. Sometimes you'll get a failed bubble. You might get emphysema. You might get a type 2 bubble. Many things can happen. So you may want to resort to a manual DALC as a recovery option. You in extreme ectasias like in the picture there, you may have the big bubble we know doesn't go beyond the central 8 mm or so of the cornea. So if you have a peripheral ectasia, it won't really dissect in that area, so you might want to use a manual technique. Or if you have an extreme ectasia where the working space is less, high-risk grafts where you just don't want to have a perforation or a type 2 bubble. If there's involvement of the posterior cornea, like an old hydrops case, like in this OCT, you can see some irregularity at the level of the desmes. Such cases, a desmetic DALC, like a big bubble DALC, will have a high risk of perforation, and a pre-desmetic manual DALC might work better. Or any other contraindication for a big bubble. So what are the challenges with the usual manual techniques? Usually you have to do a layer by layer dissection where you'll end up using a sharp instrument in the central cornea. There will be a high perforation rate because you're using a sharp instrument. You may end up in an irregular bed, or you may leave too much stroma, and that can cause interface scarring. And because it is very skill dependent, the repeatability is low, and not everybody can do a good job with this kind of a technique. So we have described this technique called the groove and peel technique. My timer isn't working, in which we basically, we get a partial thickness trephination using whatever trephine you're comfortable with. You could use a vacuum trephine or a manual trephine. You have to make sure that you encompass the disease in your trephine. Here we had attempted a visco bubble at the time we were trying that. So we decided to, we didn't get one, and my threshold for converting to manual DALC is very low, so I immediately converted. So what I do in this technique is I use a blunt scissor to kind of create a dissection underneath the trephination edge. Earlier I was using the universal scissors, now I use a scissor which has been designed by Joja Surgicals. No financial interest. So we go on doing this kind of a scissor dissection, go with a closed blade and open it, and you keep opening this space, and then you cut where you have dissected like this. So you complete one round and then you spiral into a deeper plane. You may have to do 1 or 2 or sometimes even 3 rounds, and at some point you'll start seeing this shiny tuas layer, which is much different from the stroma. So once you've exposed that, expose about 2-3 cloacas of that. And the beauty is, after you've shown, open up this potential space, you don't need to dissect anymore. Just using stretch forces, using 2 forceps, one giving counter traction and one holding that central island, you can just strip that entire stroma off that interface, and it really peels off quite well. And because the stretch forces are distributed over a larger area, you don't really end up with a perforation very easily. And you can see you get a very nice clean bed, just like you would with a big bubble DALC. And I've been using this for so many years now, and over years I've found that in my hands this works most repeatably, even better than a big bubble DALC. So we just designed this little scissor. It's time at 4. Yeah. From Joja, like I said, I don't have any financial interest. So the advantage of this scissor is got this little narrower tip, and of course it's a blunt tip, so it can be inserted into that groove very easily. So what I do is often, after I've made one round, that central island, I trim its edges so that I can see where I'm dissecting quite well. So you can see, doing the same scissor dissection, and then you just basically grasp that central island and peel it off. You can do it in one step, or you can do it slowly, one by one, so that you have a more controlled kind of a peeling. The idea is you basically distribute that stretch over a larger surface area. And if you have any areas attached, you can use any blunt spatula to kind of just release those attachments. So this is just a representative picture. First post-operative day, you can see the interface is very clear, just like you would in a big bubble DALC. Keratoglobus particularly, this works very well because the attachments between the stroma and the deeper layers are very flimsy, and it peels off just like a LASIK flap. As you can see, there are no attachments at all. So it opens up that interface very nicely. Again, in edematous corneas like therapeutic DALCs, because the stroma is very spongy, it peels very easily. So it's not that you can't have perforations. Here was a patient who had an old hydrops where we tried, and we did have a perforation, but in spite of that, if the perforation is a straight cut, you can manage and complete the surgery very well with the DALC and have a good outcome like you can see in this case. So this is just one slide I like to show in the end. One of these eyes has had a big bubble DALC and one has had a manual DALC with the groove and peel technique. And both look identical, as you can see, even the suturing technique is similar. So manual DALC does work. The key, I think, is to use your own, devise your own technique. There are various techniques of manual DALC that have been described. This is the one that I like. But you could use principles of different techniques, air insufflation, hydrodelamination, layer by layer. So whatever works for you, you can use principles of all of them. Sometimes if I've lost my dissection interface, I thicken the bed with hydro to get an area to restart the dissection. So you use the principles of hydrodelamination for that. Or if you attempted a bubble and you've ended up with emphysema, it's like having an air insufflation, and that provides a contrast as you go layer by layer deeper to reach your deeper layers. So I've finished before time. So manual techniques may be a good alternative to big bubble in difficult scenarios. Groove and peel technique makes manual DALC safer and more predictable, and use principles of various techniques to arrive at your own manual technique. Thank you.
Thank you, Rishi, for this crisp and concise presentation. At this point of time, we will initiate some discussion, because after which we will move on to posterior lamellar keratoplasty. So for the audience, time to wake up, and if you have any questions that you would like to ask on the previous topics of superficial anterior lamellar keratoplasty or microkeratome assisted lamellar keratoplasty, or the two techniques of DALC, this is the time to come forth with your questions. Yes, please go ahead, use the microphone and ask your question.
My question to Dr. Swarb. Congratulations for your presentation about manual DALC. My question: do you have, do you need to do paracentesis before peeling or no?
Yeah, you can do that. It's not mandatory, but I often do that. It will make the peeling a little safer, especially if it's an old hydrops case or something. It's a good idea to soften the eye.
You do the paracentesis from the start, or
no, just before peeling.
Before peeling.
Yes.
Okay. Thank you.
In my technique of manual DALC, I do the trephination, and after that I do a paracentesis just to have an access to the anterior chamber.
Okay.
Because when you're dissecting manually, if you have a perforation, then to make a paracentesis in a soft eye is a little bit more challenging, especially if it's a phakic eye. So if you have an access to the anterior chamber from beforehand, you can easily go in and put an air bubble.
So you do it inferiorly?
Yeah, you can make one inferiorly as well. If you have a perforation, you want to make an inferior PI.
Yeah.
So I think this is in your surgical planning, you can think about it. If you don't have it, leave the paracentesis just like that. It doesn't harm in any way. Yes, any other questions? Okay, if no questions, maybe I'll ask Sharon. In your clinical pre-op evaluation, what do you think is, how do you decide which one to do big bubble and which one to do manual? Or do you go ahead and do big bubble in every case?
So, clinical examination, I think the slit lamp examination is extremely important, because on the slit lamp itself, rather than just write apical scar or, there's a central scar, I mark where the scar is, note down how large it is, what is the depth, whether it's involving the posterior stroma or DM endothelium. And not just big bubble, but even for, if I'm planning a manual DALC, even if it's a post-hydrops eye, very often we can still get away with doing a DALC. It's not necessary that you have to do a PK in such cases. So it's important to mark out. And also preoperatively, I like to do an anterior segment OCT for all my patients and look at that and check the scar even on that, because in case we've missed anything, and also the thickness centrally as well as peripherally. To see what depth we have to define at or mark at. So these two things are essential.
Yeah, I think the intraop OCT, your anterior segment OCT is quite important. For me, that's an invaluable tool. I always assess the scar, and if the scar involves the pre-decimates layer or the decimates, injection of air is more likely to have an abnormal response, so you do that.
Yes.
I think one more thing which is useful, especially in post-viral scars, is sometimes the endothelium can be quite bad.
Yes.
So it's a good idea to get a specular if you can, or at least look at the endothelium on the slit lamp.
Yeah, you can also look at the pachymetry, because often you cannot image the endothelium, but a pachymetry is a surrogate marker. Like if you have a good functioning endothelium, your pachymetry will be low. If your pachymetry is thicker, then you know that the endothelium may not be. One question for Rishi is that when you're doing a manual DALC, in your hands, you may be going very close to the decimates. But often when people do a manual DALC, you may be leaving behind residual stroma, which can be anywhere between 100 to 150 microns. And then if you try to put in a full thickness donor on that, your apposition of the graft-host junction may not be optimal. Maybe when the sutures are in place, it may look well apposed, but when you do suture removal, you do see a small ridge on the, or on a topography, you will see a peripheral ring of steep area. So that's why what difference I do is for all those manual cases of DALC, I use a microkeratome, use a 400 micron head, and my donor graft is always 400 microns in thickness. And that I find gives me a much better apposition of the graft-host junction, especially if you're doing a manual DALC rather than putting in a full thickness graft.
I'm just wondering, would slightly oversizing take care of that as well?
Oversizing, yes, you will avoid too much of flattening, but oversizing the graft, especially for ectatic disorders, can sometimes result in myopic shift in your refraction. Yeah. Because sometimes we use the same size donor to try and compress the cone so that you have, a normal keratometry values.
So I have a funny question, like you are doing DALC and the Pachy reading, endothelium is fine, Pachy reading of the patient is around 620. So how do you manage the donor?
No, like I said, if preoperatively, I usually always assess at the site of trephination what is the thickness I am working with. And based on that, I decide, because if you have anything less than 500, 550...
No, I'm talking about more than 600.
Of the donor, this is donor cornea?
No.
Recipient.
Recipient. I have two patients.
In the center or in the periphery?
In the center. 637 and 642. So my question is different. So I was thinking, I have not done it. So I was thinking that if I do that, like we used to give 500 micron. So I'm putting 500 micron, we are closing the anterior surface. Later on, there will be posterior. And immediately I will not understand, but there will be some posterior float, posterior steepening will be there. So my thinking, I have not just, you have done so many.
What is the indication for this DALC?
That is a scar.
Scar.
Central scar.
A scar with 650 micron to me looks like the endothelium is not working, sir.
No. Endothelium is normal. Okay. Normal. I have seen from all aspects. Central and four different points. So that is a different case, but rare. But to me, I do not have any answer.
My question, Dr. Rajesh, do you prefer the same size graft in all cases of keratoconic patients, or oversizing, or well, how to decide the size of the graft?
Sometimes when you have a very steep cornea, if you use the same size, if you're doing a big bubble, it is still okay. But if you're doing a manual DALC, you tend to get these posterior folds. And some of these folds, they can affect your visual recovery. To reduce the amount of folds, you can slightly oversize the graft so it does not flatten the cornea too much.
Okay.
But other than that, in most ectatic disorders, you try to use a slightly larger graft, and it's usually the same size. In other indications, I don't make it oversized by 0.5 like what you do in PKP, but oversized by 0.25. 0.5 is too big because you still have a closed chamber. Sometimes the donor will not sit very well.
Okay. This is I noticed when I used the IOCT at the ends of the surgery.
So, again, I have a question to all of you. I faced earlier. Now I am not doing DALC nowadays. The question is, if you consider the other eye of the patient, like C3 treated eye, patient stable, one eye advanced. So the dioptric power of the other eye is -8, -9. Now, what will you choose the graft size in the operative eye?
Well, if the patient is myopic in the other eye,
and not contact lens intolerant.
Yeah, but what's the vision like? If the vision is okay, we can...
With glasses, she's fine. 6/9/6/12. But in the other eye, you are attempting DALF because the central scar is there. That question to
I will not try to.
I use more oversized that because I have when
Yeah,
I
but
was
I will not aim to make the patient -7, -8 in the fellow eye. I will try to get back to normal keratometric values, somewhere between 43 to 45 diopters, and then come back and see. Maybe we can do a phakic ICL or something like that in the fellow eye to match that.
that is the question. Okay.
Yeah, I have a question to Dr. Sharon. Yeah, sir.
Yeah, that will be the last question, and then we'll have Pratik. Yes.
Yeah, your way of doing DELC in very thin corneas, with thickness of like 200 or 225, does it differ from your routine DELC cases?
Yeah, so when we have a very thin cornea in the center, as you were saying, 200, 250, the challenge there is if you do an anterior lamellar stromal removal, you remove a layer, then the residual stroma in the center would be very, very minimal, and sometimes it's not possible to get a big bubble in those cases. Of course, dissection, in the anterior dissection itself, you may perforate. So one way of doing that is that you do your, if you're still planning to do an anterior lamellar dissection, is that you do the anterior lamellar dissection from the periphery and leave behind the area which has the thinnest part of the cornea. You leave that area as a flat, and you'll have enough access to do your big bubble still. And then once the bubble is formed, you can complete your lamellar dissection, or you can leave it as an island. So both these techniques work very well, and it's great, no problem. Or if you're comfortable doing the bubble without doing an anterior lamellar dissection, that's fine. But otherwise.
We will now move on to endothelial keratoplasty, and we have Dr. Pratik Guchar from Sudarshan Netralaya, and he'll be talking to us about decimet stripping endothelial keratoplasty, a simple approach.
Yeah. Good afternoon, everyone, and thank you, Dr. Fogla, sir, for giving me this wonderful opportunity. I'll be speaking on decimet stripping endothelial keratoplasty, a simple approach. Now, for a simpler approach, you need to break down the... I'm not able to move this slide. Yeah, you need to break down the surgery into steps like donor preparation, recipient preparation, and tissue insertion unfolding. For donor preparation in cases of DSEC, one important factor is the size of corneoscleral rim, which should be at least 2 to 3 millimeter in size so that it fits properly. You can mount it properly on the artificial antechamber. You can then prepare your donor either manually or using a microkeratome. Recipient preparation, we know that you need to remove, need to do a decimet or rhexis, and then PI is an optional but recommended procedure, and then tissue insertion and unfolding. So for donor preparation, here's a clip for manual donor preparation using artificial antechamber. Here we are using one made by Katina, and we have steel and titanium one also available in the market, which have these antechambers have inlets for, you can push in BSS or MK corneal storage medium to fill it to the brim, and then you take the donor and you place the donor endothelial side up, and then put some visco, and then you place it, center it, you mount the cap and the screw, and then you tighten the screw, and this way you are able to assemble it, and then the globe has to be firm before you make your incision. Here I'm using a 400 microns guarded knife to initiate my incision up to 3 clock hours, and at the limbus then you can initiate the dissection with the help of a crescent. And you can hold the artificial antechamber with the other hand so that you can tilt it a bit so that you follow the curvature of the cornea properly. This is the first lamellar dissector which you use up to the center or more than that, little bit more than that. And then you can, once you cross that, you can take the curved one and you can dissect it. A second pass you can do to get an ultra thin graft of less than, less than 100 microns graft if you want. I think Dr. Fogla sir will be covering that. Then you can mark the center of the cornea and gently disengage it without causing endothelial injury. And then you can put it on the Teflon block, endothelial side up. Here I'm using a manual disposable trephine. You can use a suction punch if you have, and then you can center it properly and then just punch it through. And this is pretty much what we do for a manual donor preparation of the graft. For the recipient preparation, you need to remove the epithelium most of the times to get a clear view of the anterior chamber. You can then just mark the anterior corneal surface, which act as a guide for your descemetor, which in turn depends on the wide to wide diameter of the cornea. You can make two side ports. I am sitting temporally, so you can make two side ports. Here I am doing the descemetor axis under viscoelastic cover, and you gently score 360 degree and try with the help of a reverse Insky hook and try to bring the descemetor, the donor diseased endothelium to the center. Try not to be, you have to be gentle so that you do not strip the stromal fibers. And once you bring the whole thing out of this, you can just gently pluck it out. It's important to wash all of the viscoelastic material from the anterior chamber before, and then you can, PI is definitely preferable. You can do an inferior PI at the end of it. So you can also do a manual descemetor axis under air, which is preferable because you don't have to wash all the viscoelastic, which might get trapped in the interface when you are inserting a graft. Also, with the help of air, you get to see all the remaining DM tags, which can be, disturbing and cause graft detachment, especially in DMAC cases. But with air inside the anterior chamber, you need to practice more, because whenever you enter the anterior chamber, the air tends to leak out from the anterior chamber. So in this case, I have already done a phacoemulsification from the superior nasal incision. So from that, you can just take out your descemetor membrane. Anterior segment OCT, as in DELC, it's also a valuable tool to evaluate in the cases of DSEC. Here, most of the times you can see cases which have delayed presentation, where you have associated epithelial hyperplasia. So you get to see, evaluate with the help of ASOCT whether there is associated scarring is present or not, and you can decide whether you want to go ahead with a penetrating keratoplasty or an endothelial keratoplasty would be good enough for this case. So once you remove this in toto, you can get a relatively good view of the anterior chamber. Sometimes in the recipient preparation, you not only get a poor view like in this case, but also once you remove this, you have to evaluate beforehand that this case has a lot of peripheral anterior synechia, more than 270 degree of anterior synechia. So you have to be carefully remove all these anterior synechias, which you can do either with the help of iris spatula, putting some visco into the anterior chamber, and then gently you have to release it, not causing any iridodialysis, and the iris may bleed in this maneuver also. So you have to be very careful and gentle in this. One can also use micro scissor to gently cut all the synechias. One important aspect in these cases is the graft size, which has to be a little smaller, like 7.5 millimeter in this case, because these anterior synechias tends to reform after some time. Coming to the donor insertion. Donor insertion, I usually follow a simple approach in which I use a cystitome, which is made up of 30 gauge needle and bent at the tip. And with this cystitome, using a 5.5 millimeter clear corneal or a corneoscleral incision, you can insert the graft endothelial side down. So here we making a cystitome, and this is the donor graft. I usually inject air after completing my descemetor axis and PI, and while I punch it, keep the antechamber filled with air. So you have to remove that air. The incision size is like 5.5 millimeter. You take the graft, coat the corneoscleral bed with viscoelastic, and gently put your graft endothelial side down, and with one stroke it goes smoothly inside the anterior chamber. Once inside the anterior chamber, the corners which are like rolled up can be smoothened and unrolled with the help of BSS and gentle tapping on the corneal surface. Once it is unrolled, you can put air inside it in the anterior chamber beneath the graft, suture the main wound, and complete your DSEC by filling the anterior chamber with air. So again, a small video. Again, we are using the same cystitome needle push technique, in which we put the graft endothelial side down, and once it is inside, you can gently push it. As you can see, you need not to worry about the orientation of the graft, because it's already endothelial side down. Gentle tapping and deepening of the anterior chamber with balanced solution will unroll the edges of the graft. Then you can put little bit air, and then you can close the main wound with a suture. And after that, you can manipulate the graft by just gentle stroking on the corneal surface, or you can even use reverse Insky hook to center your graft. And once it is centered, you can just go beneath the graft and put air inside. And this pretty much completes the surgery. You can see the double rim sign of the donor tissue, and you can put a BCL, and you can just get away with the surgery very easily. So to conclude my session, the simplified DSEC, you need right set of instrument. Investing in right set of instrument will make your work much easier. A lot of wet lab practice, especially if you are doing manual dissection, donor tissue evaluation, as I said earlier, a 2 to 3 millimeter rim is very important in these cases, and complete ocular examination with surgical planning and execution is important. Thank you for your patient listening.
Thank you, Pratik, for simplifying the DSEC procedure. He really made it look very simple. Now, I'll be talking about ultra-thin DSEC. And can I have my slides on the screen, please? Yeah. So ultra-thin DSEC, if you look at the anterior segment OCT, you can see the differences between DSEC, where the usually donor is 130 to 200 microns. In ultra-thin DSEC, we try to go thinner. Ideally, it should be less than 100 microns, but it can range from 70 to 130 microns at the time of implantation. And DMEC, where the isolated transplantation of decimus membrane, it's only about 10 to 15 microns thick. This technique was popularized by Massimo Busin, and he described the double pass technique. And in this, if you compare the outcome of ultra-thin DSEC versus, there is something. Shall I change the connector? Yeah. So if you look at the comparison between ultra-thin DSEC versus DSEC and DMEC, you will find that the outcomes of ultra-thin DSEC are definitely better than DSEC and comparable to DMEC. The visual acuity between DSEC and ultra-thin DSEC are different because the rate of recovery is much faster when you do the ultra-thin DSEC. So this is a 49-year-old female who had had a complicated cataract surgery presenting with pseudophakic bullous keratopathy. There is some inferior iris tissue loss and was planned for endothelial keratoplasty, wanted to do a DMEC, but the eye bank tissue that we got was an 18-year-old donor, had very good endothelial cell count. So we decided to go ahead and use this for ultra-thin DSEC. So how do you prepare the donor? The double pass technique. So here we use the corneoscleral rim provided by the eye bank, protect the endothelium using viscoelastic. Then you mount it on the artificial chamber, after which we debride the epithelium, perform a pachymetry. You can see it's about 654 because it's stored in MK medium. Tissues are a little swollen. And then we use a 350 micron head to make the initial pass to create the free cap. So this is using the Moria SBK microkeratome. That's the anterior cap that's removed. After which we then go ahead and do a pachymetry again, and you find that now the reading is showing as 210 microns, and there is a nomogram with which you can go ahead. So I'm using a 90 micron head for the second pass. So ideally from 210, if you use a 90 micron, you should be left behind with about like a 120 micron thickness lenticule. So that's the second pass. We actually rotate the graft to make the second pass from the opposite side because the initial cut depth is a little deeper and it becomes a little superficial as you go to the opposite end. So that's why you want to reverse so that you can avoid perforation. So there you can see that that's the thin lenticule that's been removed. We do a pachymetry, intra-op pachymetry again, and we see that our measurement, there is a little bit of variation. We were attempting a 120, but we ended up with something like 77 microns. Before you go ahead and take off the tissue from the artificial chamber, it's important that you mark the edge of the microkeratome cut. Otherwise, when you are punching from the endothelial side, you can punch a little eccentric, so you will have variable thickness in your donor. It may be very thin on one side and like a full thickness on the other side. So that's the patient's eye where we debrided the epithelium and did the rest of the steps of surgery. The inferior iris loss, so we decided to do a pupilloplasty as well. So you can see that we did the pupilloplasty. And then we take the donor tissue from the artificial chamber. So we have our peripheral marks that helps us in centration. We also put a F stamp to help identify, because unlike the regular DSEC graft, an ultra-thin DSEC graft is very flimsy. It can get flipped over very easily. And before we load it onto the injector, we put a little bit of viscoelastic, do a trifold. If you don't do that and you try to pull it like the regular DSEC graft, it can flip, it can curl the other way. So doing a trifold is always easy. That's a Macaluso inserter we are using. You can use any, you can even use a Bucing glide. The AC maintainer is keeping the chamber form. Using a micro forceps, we pull the graft into the eye. And then once the graft is inside, we secure the wound. And now we are trying to see here, the graft does not snap open quickly like a DSEC graft because it doesn't have too much of stromal volume. So you need to deepen the chamber and do a little bit of tap on the surface, and you can make the graft to open up. And because we put a little bit of cohesive viscoelastic on the surface, when you fold the graft, the folds also get stuck in the viscoelastic. So it takes a little time to just get the folds to open up. Once it's opened up, you can go ahead, put an air bubble below the donor disc. So here you can see that I'm going in, and as I put the air bubble within the scroll, it kind of opens up. To move the graft, you need to make the bubble which is slightly smaller than the size of the graft, because if you keep a large air bubble, it's difficult to make the graft move because the air bubble pins the graft against the host stroma. Once it is well centered, you can go ahead and you can put in a large air bubble. So that's the post-operative outcome. Even you can see by day 4, day 5, the cornea is looking extremely clear. It's very thin graft with good endothelial cell count. This is something that, again, you can prepare that manually as well, where you do the first layer of dissection. After you have done your dissection, you cut at the edges to reflect the cap. And then you can go ahead, make a peripheral groove and do a second layer of manual dissection using the lamellar dissector. So thereby you can prepare a ultra-thin DSEC graft manually also by doing this double layer dissection. And for insertion, yes, you can insert using the inserter like what we have shown you here on the Macaluso inserter. You can, it's very good for eyes where the cornea is hazy, where you cannot do a DMEC. An ultra-thin DSEC graft is a good alternative, but you can also put in this graft pretty much like what you saw Pratik do. So this is a patient where had a failed DSEC with the AC IOL, which we replaced with a scleral, with a posterior chamber IOL. And you can see the ultra-thin DSEC graft can also be inserted using the same sliding technique. You put in your graft on a bed of viscoelastic, and then you use a bent needle to just push the graft quickly into the eye. The edges tend to fold a little the reverse way because it's very thin. You can go on the stromal side and gently nudge the folds to open it up. And because it's an ultra-thin DSEC graft, you can make larger grafts as well. So I have implanted 8.5 or even 9 millimeter because unlike a regular DSEC graft, which can have peripheral synechia, here that is not the case. But you do need to measure the corneal diameter before you decide the size of the graft. So the advantage of doing an ultra-thin DSEC graft is that it has the same surgical principles of a DSEC graft, but the visual outcomes and the risk of graft rejections are much lower, and they take the benefit of DMEC, which Dr. Samar Basak will be talking about in the next presentation. Thank you for a patient hearing.
Thank you, Rajesh, and wonderful talk on ultra-thin DSAK and also manual one. And this is the last talk. I'm in the last 2 layers of cornea. I'll be talking on DMEC, keep it simple. I do not have any financial interest to disclose. If you see this graph, this is from US domestic surgery use. If you see the last year figure, DMEC is almost touching the figure of DSEC. So this year, they will definitely cross this figure of 49.5% of DMEC of all EKs. In India, probably 100 surgeons are doing EK regularly in any form, but 2022 figure, the DMEC is only 18%, only close to 500. This is the source from EBI. Probably this year it will be increasing by another 50%. So, DSEC and DMEC, you see the figures. Always you will choose the right side figure, and patients are happy, you are happy, highly satisfying results. So initial cases are with very good visibility. So you have, if primary cases like Fuchs dystrophy with cataract, and more commonly the pseudophakic corneal edema or bullous keratopathy with good anterior chamber anatomy, and IOL should be in the bag. An ideal donor tissue for the beginner, that you can use any MK medium or corneal preserve. The donor age is 55 to 75. As Rajesh he has used the younger donor for ultra-thin DSEK. But people are using gradually lowering the age of the DMEC graft by different methods. And endothelial cell density should be more than 2500 with good morphology, and standby optical quality tissue for fast 20-25 cases. There are different steps. You have seen many steps in previous two, but here the main important is donor preparation, the first hurdle, and second one is donor unfolding. That is the more difficult part. So you see that this is little different from DSEC or ultra-thin DSECs. We take little larger desmetodexis, usually 0.5 or little more, and AR-assisted DMRexis always gives the best visibility, and it should be done in scleral fixation or SEIOL, because we don't use any viscoelastic in those cases. And ensure that any remnants of DM should be removed in all situations, because that will be a cause for your donor detachment. And this is another important step. You have to follow the inferior PI. You do it manually by inferior port, or maybe using a vitrector. Check always the patency of the PI, but there is little oozing of blood, and you need to keep air tamponade, and this is very important in DMEC. And this is the point I usually prepare the donor. In Western world, they are all using all PPPPP DMEC graft. In India, all are doing. Recently, Ramayamma, and they have sent me 2 tissues for test, how they are using pre-pill tissue to surgeon, and I have used 2 tissues, and the patients are doing fine. The donor preparation failure is around 1 to 4%. So here we use the simple double punch trypan blue technique, and this is going in my hand for many cases. And you see that you remove the peripheral part, this is not beyond 9.5. You leave the donor edges and separate the edges, and then you can do the peeling in one hand. You don't need a fancy instrument like suction refine, and this is only McPherson forceps. You go up to 90%, make a stromal hole, and then this is for making a asymmetric mark from the DM side, because you need to identify. Rajesh has showed F mark or S mark. So here you put an S mark, and then you flip the cornea back, and the desired size is 7.75, 8, 8.25, 8.5, whatever your donor is. Normally we select the donor age by keeping the 1 millimeter working zone on either side. So this is then you take into the syringe. And this is one of the important thing, that if you have a fine instrument, like you can use the simple chopper. So if you go up to like 1.5 millimeter, 360 degree, I am telling you, there will be no radial tear in these cases, because what happens, some stromal attachment remains there, and here younger surgeon is doing the operation. This is from live surgery. Younger colleague is doing the surgery. I have taken his video. His stand is more steadier than me. So, but when you have a little tear at one point, like in say 2 o'clock position, you make a small Nike kind of sign or right tick, and then you do not have to think about the tear will extend up to the periphery. This is one important tips for all, that you should respect the sides of the DM peeling. This is thing. Then donor transfer and insertion technique, and there are several techniques, several things, but probably the principle remains same. Choose a technique which is consistent in your hand, then master it. Ultimate goal is ease of unfolding with less cell loss. So this is the beautiful YouTube site. You must go, Peter Wellman. You will learn a lot of things. But the color, if I make the color iris brown, then this thing will be difficult for all of us. Like they have it. So I try to see the scroll type. Even now I practice this. Unlike Rajesh will show in my course that he is using several other techniques, and those are also wonderful technique. So this is also important. Check the air bubble. If air bubble it will not go in, probably it will come back. So you make free that air bubble should not be there, and then usually unfold it. This is another thing, release fluid while injecting. Rajesh used one unilateral flow of fluid by AC maintenance. That is also wonderful concept, so that your AC remain at a smaller, shallower depth. So you release air and always keep a guard in your main port. I do not put suture, so I put a forceps there. And then if you have a perfect school, as I saying that even in this, I try to do this, and 65% time I am right. So when you are this thing, you do not have to tap. You just release the fluid from the side, and the donor unfold automatically. So there is no tap, tap, tap. There is no tap, tap, tap. From both sides, I am releasing the fluid. It is perfect scroll. So both sides it is unopening. So you just center it with little pleasant air. You have to put your needle tip right at the center. Otherwise, graft will shift, and then you have to redo the process again. Then sometimes you have a fold like this, taco fold. So here one side you have to pin it, and another side you have to move it. And here you have to put suture. You may not, but your direction of the stroke should be away from the main port. This is when you can see this is a lighter iris, so you can see the S mark also. But sometimes this S mark, you see that S mark is, I do not know whether you can see it, it is reverse. So you little open it, confirm it, yes, it is reverse, then you flip that. This happens maybe 20% time, maybe 25% time, just one fluid burst, you see that it just tumbles like this. And when it tumbles like this, your job is done. You now again play with your fluid release and stroke. Then even after complete opening, you see that S is reverse. Then what will you do? You just again play with fluid, very gentle fluid, and it flips like this. And always I am fan of 1 cc syringe, because that gives me very good control other than 2 cc, 3 cc or 5 cc. I never use 5 cc syringe. So sometimes you need this kind of tight scroll. So here there are several techniques. I have beautiful, Rajesh, a beautiful video. I try to push it harder. So when it hits the other end, so it opens up little. So when it opens up little, I get the edge of the, like a taco, then I pin it there, then you do that. It takes little time, but believe this, in tight scroll, it never in reverse way. It never goes in reverse way. So tight scroll, it takes little time. And sometimes, it is fun. So you take the tissue, this is little older tissue, I know how it is there in this plastic syringe. You go push it, it opens. And it is in right direction. This is real-time video. I check after tapping, yes, it is right. So I put the air. So this is very important that you can see the ace by playing your needle against a steel background also. So air injection must be optimum. It should not be full. Otherwise, when you see the patient this 1 hour lying down, you must have this kind of fluid level, and 60-70% time it is like this. I see in the slit lamp in the OR only. And then I send the patient to the ward, I take the patient. But if it is like this after 1 hour, sometimes I always think, air expanded. Like in myopia, you cannot, post-VR surgery, you cannot actually control the air. So your thin fluid at the margin around the limbus, you will not see. Then you burp little air, and immediately you get this fluid of like 1 millimeter, 1.5 millimeter. You are happy. And ask the patient to, 90% patient usually go for work after 2 weeks or 3 weeks or so. So in summary, we need to do a lot of EK in any form. Cataract surgery rate, again we are in pre-COVID level of 6.5 million at this point of time. And that means every year we are, if we consider 0.15% of incidence of PBK or edema, every year we are adding 10,000 patients to our list, but we are doing only 500. So there are a number of Fuchs dystrophy, especially in Bengal, and surgical visual outcome of DMEC is just like phaco surgery. And as a corneal surgeon, we need to go with this wonderful surgery. Thank you very much for your patience hearing.
Thank you, Dr. Basak, for that wonderful talk and those interesting videos. We are just out of time, and so I think the discussion will have to happen on a one-to-one basis. I would like to thank all my co-instructors without whose participation this course would not have been wonderful. And we were able to cover all aspects from anterior to posterior lamellar keratoplasty, although on an individual level, each topic requires a separate course. But I think this would have given you an overview of all the aspects of lamellar keratoplasty that we are currently performing. Thank you, everyone. Lovely. Lovely. आप लोगों ने बनाया.